Good afternoon. My name is Jim Moss. As the moderator, it's my goal to have this as an interactive session with questions between you and the panel members at the end of the presentations. I request that when you ask your question, please identify yourself or your organization. And I'll ask members of the panel if they can hang around afterwards for me. All right. Now, if you can't hear me, please raise your hand. All right. Our first panelist is Helen Goins. Dr. Goins is a PhD in psychology and has a 30-year career as a substance abuse counselor. And she's still alive. She's a psychology professor at Union and works at the Cumberland River Behavioral Health. She teaches what she practices. They tell me that she is a lifelong learner and does not only teach but practices for self-education and self-discipline skills. Tom McClure is a native of Knox County. He's a graduate of Berea. He's held a number of senior management positions, including Save the Children and the American Development Foundation. Tom has worked in the development of community-based groups addressing addiction prevention and treatment in places such as Central and Eastern Europe, Romania, Serbia, Croatia, Egypt, North Africa, and Mexico. His resume is just very impressive. In his career, he has assisted human rights and promoted social change. Rhonda Hughes is the director of Horizon Health, and I asked her what she did, and she said, "I'm just a master of all trades." Horizon Health provides services, transportation, housing, group therapy, medication-assisted therapy, primary care, and individual care. And I feel privileged to be part of such an impressive group. So, Dr. Goins, would you like to start?
Sorry.
And we'll see if, I'm going to try the lights down and see if it'll help. Y'all let me know if it's an issue. Is this better?
Yes.
No? You want the lights on?
I'll fall asleep.
Dr. Goins?
Are you going to operate that thing?
No, ma'am.
I don't know that.
We have an expert right here.
For you? Do you want me to try for her to operate the source? Oh, okay.
Let me know when to advance.
Are you comfortable with me?
Yeah.
Okay. The thing I like to work with most is co-occurring disorders. Actually, I think that everyone that comes into treatment has some kind of co-occurring disorder. It might not be clinical, but they come in with a lot of baggage. So to provide the best possible care for our clients, our objective as part of a treatment team is to provide the best possible care for the client. So the focus should be on the client when he enters treatment. I'm writing a proposal treatment guide, and really it's from the perspective of inpatient rehab treatment. This is for the patients that are adult males who have both alcohol or drug addiction and a co-occurring disorder. We have to remember that the client is not an interruption in our ethic routine. He's the reason we're there. So treating the person, that is the whole person, not just the addiction. Referral sources may be made by legal entities such as local courts, probation, parole, social services, families, employee assistance programs, or maybe even a certified DUI assessor. A lot of times, clients don't know what they're getting into when they just call. And they'll say, I got a DUI and I need to come to treatment. He thinks it's going to be swift. So, but we need to explain to him what's involved. He needs to know. My particular interest is in treating the client who presented with a comorbidity issue. I read a lot because new research is where it's at. Lynn and John Sperry, 2020, gave us their expertise or strategies of planning and focusing on treatment interventions. And treatment begins with our first contact with an individual that's referred for substance abuse treatment. So the client needs to hear a rationale for treatment. He has his own, but we might need to help him with it. The referral source is important, but it might also guide our interpretation of his symptoms or his situation. The client's interpretation may not be the best source of information, but his rationale should be respected. And it's up to us to clarify things for him in a calm, friendly manner. Our rationale for his treatment process should be based on his individual needs. One size does not fit all. Substance abuse treatment entails commonality to fit all, but each client is unique. So we need to be sensitive to his uniqueness. The screening process begins the assessment process as well. So when we're talking to a client, we're always assessing. Understanding presenting symptoms. Referral sources are going to vary, and that depends on their maladaptive behavior patterns. His current presenting symptoms may suggest only an alcohol or drug issue is the problem. He may have underlying factors that could explain his current presentation. So what happens when the client has anxiety and depression symptoms? The client presented himself to have symptoms of anxiousness and a sad affect. He reported multiple legal issues of drug use, as well as a history of suicidal ideations in the past, but he had no current plan or any current suicidal ideation. So he reported, though, having mental pain. He's unemployed due to his chemical use and missing work. He reported family conflict due to his chemical use, and he is court ordered for the 90-day treatment program. So this is the role of the screener, who is the first person he has contact with. As the screener, you present to be supportive, friendly, and interested in his treatment needs. The purpose of the screening is to gather information as to his appropriateness and eligibility for the treatment program. And you determine that he does need treatment for his addiction issues, but he also needs a psychiatric evaluation to determine if he needs a medication evaluation as well, due to his anxiety, his sad affect, and as well as his previous suicidal ideation. So you explain to the client why you need to make a referral. And just because his suicidal ideation was in the past, that doesn't mean he's not going to have them again, because he still has the same baggage. So the role of the screener can empower the client by making supportive comments, such as part of you appears to be very strong and can help you to choose to cope with your problems actively. Although your alcohol and drug use has not been the ideal way to cope better, there are better ways to seek support. Pondering suicide. So when your situation looks bleak or is causing stress as well as other problems, this is a common human experience. Thinking of suicide is not equivalent to causing a death, but can suggest low risk. So we evaluate suicide risk. Kano, 2018, informed us that Cole, 1993, described low-risk suicidal thinking patterns, but the client that he could be provided services in an outpatient setting rather than having to go to a hospital. He could be treated and stabilized with medication. And her goal was to empower the client and preserve his dignity by connecting the client with medication and other resources. Evaluating suicide risk. Kano, 2018, provided information for determining the level of risk when a client reports having had suicidal thoughts. And the key is to act quickly and decisively when a client also appears to present with a sad affect and a history of suicidal ideation. So when referral to the hospital is needed. So we explain to the client, he understands that he can return to treatment if he's cleared by the attending physician. He signed a release of information to allow the center to check on his progress. He's transported to the hospital emergency facility. His referral source, that is likely the local court, was informed of the referral made to the hospital and his admission for stabilization. The role of the co-occurring disorder diagnosis. When a client's admitted for stabilization at a hospital, he generally remains there 3 days, could be 5. He was given a diagnosis of depression and anxiety. He was provided with medication for support and a prescription for an antibiotic for his dental issue. He returned to the treatment center. That might be all I have. No,
There's another about 13 slides.
it's about what?
13 more.
13 more. So what to examine? Mental status examination. This would include that the psychiatrist is paying attention to the client's appearance, his attitude and activity, his mood and affect, speech and language, his thought process, the content of his thought, and the perception, his cognition, insight, and judgment. How to listen and ask questions. Do not be directive during the beginning interview. Listen not judgmentally at first, and then questions can come later as you build a rapport. Be aware of your own personal biases and emotional states that can influence and potentially distort your understanding of the client. That was from Summers and Plank, 99. When clients are asked too many questions, it can interfere with the rapport between the helper and the client. However, clients need to have opportunity to talk about what they need and they want to talk about. Also, Summers and Plank. Listen and confront. Confrontation is a means to help clients perceive themselves in reality more clearly. They often have distorted views of others in the world and themselves. When using confrontation, you must be sure that you have a strong working relationship. Summers and Plank. With individuals who are abusing alcohol or drugs, confrontation must be convincing, firm, and repetitive, sometimes even harmful. By responding with compassion and empathy to the client's emotional pain and intellectual conflict, you express concern and acceptance. Y'all have to excuse how I talk, that's a chemo issue. It's not going anywhere.
Would you like to have 2 more minutes?
That's a,
Okay. All right. Thank you.
Thank you.
Todd, do you feel, you want to go next?
Oh, let me follow the next one.
Pardon?
I'll go after whomever, or I can go next.
Ellen?
I don't have a presentation.
That's fine.
Okay, what do you want me to?
You've got 10 minutes to
Okay,
share whatever you like.
well, a lot of the things that she was talking about, especially when it comes to doing assessments, one thing that I noticed that we have some missed opportunities when we do these assessments. I have sat with people and done assessments, and we'll get through questions, you know, and sometimes you have to stop, and that's okay. You may have to take a break. You may not be able to do it all in one session. So we work with the client, you know, it's really up to them. They kind of drive the session. But they will answer a question, like a good example that I can think of is, have you ever been arrested or involved with criminal type charges? And well, yes and no. You have to say, okay, and this is where we miss the opportunity. Our counselors, a lot of times, will just keep going. So, okay. You said, now, and give the client the chance to clarify. Because a lot of times when we're doing assessments on them, if it's during their first 30 days of treatment, they're really not thinking that clear. So we've got to take that into account, that all of their faculties are not working as they're supposed to. So we need to, like I said, let the client drive the interview. And we get a better assessment that way. And we establish rapport along the way because you're giving them space. You're allowing them to be individual and talk about themselves and things that they're comfortable talking about. So that was one thing I picked up from her presentation. At Horizon Health, I don't know if you want us to talk about what all we do there. Is that okay?
Sure.
Okay. We have a campus of care. And I say that to say it's a one-stop shop. And what we've done is looked at all the barriers that people face with treatment. So we thought, okay, a lot of times we'll have traditional services that'll come in and say, okay, we're going to make your MAT appointment over here. Then you're going to go to counseling over here. And then when you're done with that, you're going to go over here for something else and over here for your lab. This is something that's not fully functional yet in their faculties, and we're giving them 4 different places to go on 4 different dates. I can't even juggle that. And I think I have most of my faculty. So what we've tried to do is schedule it to where they have a stagnant appointment. If they come in on Monday, and that's the day they want to come in, they come in on Mondays forever. Monday at 10 o'clock is Mr. Jones's time, and that's when he's here. And they like that because it gives them stability, and they know that it's every week at the same time on the same day. So when they come in, we also we offer everything to them. If they say, I'm struggling with addiction, but I'm hungry, my kids don't have anything to eat, we're about to be thrown out of our apartment. Okay, what's the most pressing need do you think they have? I think it's they're going to be thrown out and they're going to be homeless and they need to feed their kids. So if you address those needs before you get to the other needs, you're addressing the whole person and you're providing the best therapy for them, the best outcomes. We have just recently got into transportation services. That was a big, major barrier that a lot of people talk to us about. So we've established that program. Our employment services are geared specifically for people in recovery. They're not just your walk-in everyday employment services. They're built on a level to relate to patients that are in recovery. And we can take them from, if they walk in, they don't have a GED, they want to get their GED, we can set them up for that right there. We have free learning lab, they can come in, they can do the classes there. If they need a job, more need to go to school, we can help them with that. One of the things we do though is make sure they're stable before we send them out to an employer. We do have a network of employers that not only in Laurel County, but also in Whitley County that we refer people to, and they're second chance employers. I'm about that is the community is starting to become aware that there's a whole population that needs employment that can't get employment because of stigma associated with them seeking treatment. So we go out, we meet with employers, and we establish those connections. And by doing that, we have them go and interview with employers that are open-minded and willing to take a chance on people in recovery. So far to date, we started that program last year. We've had 265 people go through that program. And out of 265, we have 160 that are still employed. And they are employed with people, you would have thought they won the lottery. They gave me a job. They would come in, they gave me a job. No one's ever given me a chance before. So it's really nice to see that. A lot of our other services, ADHD testing, we do that as well. And we noticed a high correlation between meth users and ADHD. So we did some research and we got into the software testing of Tech, which is the only FDA cleared software that tests for the 3 core symptoms of ADHD. So we offer that at our London facility, and it's open to the public at any time. And we take ages 6 and up. And I think she has a question.
What do you treat ADHD there? I mean, what do you, I know there's a correlation, but.
Well, what we found, we looked at all of our patients, and we're talking about 375 patients when we did this research. And we noticed that the majority were methamphetamine abusers. And then we went a step further and developed a database to where we could cross-reference. And we noticed there was a high correlation between methamphetamine use and ADHD undiagnosed.
What was that last? Between ADHD and what?
ADHD undiagnosed adult and methamphetamine use. So what they were actually doing is trying to self-medicate, not even knowing what it was they were trying to medicate. They just knew something wasn't right.
They don't
So-
get high, they just calm down.
Yes,
I've had
with
numerous
meth,
like that.
it does the exact opposite. If you're an ADHD patient, it calms you down. But if you're a normal person, you take that, it makes you crazy. So it does the opposite for them. So they just knew that it worked, and that's how they. So I did want to take a minute and introduce Zach Renfro, Dr. Zach Renfro. He is our site manager and director down in Williamsburg. We have a women's housing facility down there. Poor man, he has all them women to deal with every day. Y'all say prayer for him. But if you want to say a little bit about Williamsburg, that'd be great.
Yeah, so Williamsburg, it's a wonderful facility. I absolutely love it. And our women's housing program, that's an IOP-based program. So all the women living there are going through IOP. That's 3 3-hour group therapy sessions a week and a 1-hour individual session. And what we found, because we've got them living on our facility, on our campus, and we have it staffed 24/7 with dedicated peer support professionals. And what we found is if we've got the staff there already, let's build our recovery program. Let's provide some other activities. So we started a book club. We started Zumba class. We started a creative wellness program. Think it's kind of along the lines of art therapy, but not quite art therapy. You know, we just have, let them do art and we put it up all over the clinic. And we try to every weekend get them out for an activity. You know, a couple of weeks ago, we took them out to get their nails done. We offer transportation to church services if they desire. And what we found in providing all these things, providing this kind of whole person atmosphere, this kind of campus of care, is that the women come in there and they feel like it's family. They don't feel like, oh, I'm in this medical institution. They don't feel like, oh, you know, I'm separate. They feel like I'm part of a family. I'm with people that genuinely care. And, you know, I think that is one of the biggest things in addiction recovery. See, I'm a philosopher by trade. My PhD, it's all philosophy based, right? You know, so I spent a lot of time thinking about these things. And I got to thinking when she was describing the role of the screener and the importance of the screener, I got to thinking about our receptionist, our front desk coordinator, we call it. And at Williamsburg, for example, our front desk coordinator is someone who has been through recovery. They've been through addiction. They understand the struggles that our patients are going through. So when she picks up the phone, when Nikki picks up the phone, she says, hey, Horizon Health, how can I help? She can connect with them on that one-to-one level, you know, and I think that's a huge advantage. And I think that so many places are ignoring qualified employees, qualified recruits that have been through addiction recovery. Because I think that if you're trying to treat addiction, I think that speaks a lot more powerfully than any number of degrees on the wall. You know, our case manager, she went through addiction recovery. Our employment specialist has went through addiction recovery. All of our peer supports went through addiction recovery. And then, oh, one quick thing, our counselor and our nurse practitioner, they've had children. They've lost children to addiction, right? So they understand personally. It means something to them. It's not just theory they've read from a book.
Thank you. Thomas?
Thank you. I'm glad that I followed the presentations because I'm going to talk about the kind of exciting and entertainment side of recovery. I'm Tom McClure, and I'm dealing with two aspects of recovery. One is the pre-addiction stage, and I'm dealing with that as a member of the ELKS Drug Awareness Program. How many of you are familiar with this? Well, it's a very large national program funded by the ELKS organization. It is a well-organized and well-presented, internet-based program that is for educating children, making them more aware of drugs, and kind of orienting them to to what comes with adverse use of the drugs and addiction and so on. So it is, and I will share this with you. You can find it on the internet. It's just simply a www.elks and Drug Awareness Program. And that'll open up the whole website for you. And all of the materials are free. You saw the exhibition here in the hallway by the Elks Tri-County Club. And you have comic books, you have puzzles, you have little balloons, you have all kinds of things that kids like. You know, they engage with trying to understand what drugs are, and especially harmful drugs, and also to begin acquainting them with addiction. You know, the inability to stop doing something. You know, it's all done in a preteen and a teen approach. We have a whole section on the website called the Teen Zone, and those are regular teens that have recovered from addiction, that basically are dealing with educating other people in terms of just how they got into it and how they're getting out of it. Remind me when I have 5 minutes, I'm going to switch to another. So I want to just alert you to that. I will give you my card at the end of this, and you can write me and I'll follow up with anything. I'm a volunteer, and I'm very committed to essentially following the belief that the best solution is prevention. The best solution is prevention. So that's the side of this program. This is for church, use it for your school, anything. So that is the preventive side. Now the other side is kind of I call the excitement and challenge of leaving the nest, so to speak. Let's say we talk about pipeline of recovery. Well, there the detox with the treatment section, which we've gone into in great detail. Then, actually, someday there's going to be graduation. There's going to be post-treatment. So what does the person now that's recovering from addiction, that's maybe been in it for what, 5, 10, whatever, maybe from childhood, who knows? What do they do? How do they address living outside the context of this therapeutic community, this highly costly therapeutic community, this kind of well cared for situation, the nest? is it? Drinking and drug control. Well, the way that we have a post-treatment recovery and having quality of sobriety and having longevity of sobriety is to basically encourage retreats and tours. I have a little brochure that I'll give you after this if you wish. This again is a voluntary operation at present. And what it is, I'll just read you the description. It's basically offering training, technical assistance, and consultation services for design and delivery of customized training and travel experiences to meet the individual and group recovery interests and needs. So where can you go? I ask you a question. Where can you go as a recovering addict or recovering alcoholic? Where can you go on a cruise without booze? I just ask you, have you ever seen a cruise advertised without booze? No. And also, I lived part of the time in Mexico. Who would ever think of going to Mexico without a tequila tour, huh? Well, so the idea was to offer alternatives. Give them an opportunity. Other do the fun and exciting to them in recovery, that they thought maybe they'd never be able to do again. So that's kind of the crux of this, the idea of the retreats and tours. And my approach is to work with organizations that want to set up retreats, want to set up tours, and consult with them to basically design it and implement it. And we've found now in Mexico, if you'll just put this on, we have, these are some tours that have already been conducted. For example, we call them sober tours. And Zacatelas and Guanajuato are groups of alcoholics, post-treatment alcoholics, generally in some kind of 12-step recovery program, that are touring these sections collectively together. Well, they can go to the fiestas, they can go to the highly charged drinking places in Mexico, and they can feel supported. But they're supported by their group, by their peers, by other recovering people. And they're therefore kind of able to deal with that danger zone, the zone that can entice them to go back to the old lifestyle, which they thought at one time might be fun. Can you play the next? There are cruises. I don't know, how many of you been on cruises? Did you ever find a place to not drink?
That's their moneymaker.
Huh?
That's their moneymaker.
Exactly. And it's promoted like crazy. Well, luckily we have increased numbers of 12-step meetings on cruises, that people that are in recovery, post-treatment, living a life in sobriety, can attend. Okay, and I'll wrap this up quickly. There are lots of sober travel opportunities. All you have to do is put in sober travel into Google, and you will come up with all the listings of opportunities for travel and opportunities for experiences without the liquor, without the booze, without the drugs. So I have included this. I just encourage you to look in the internet, punch in sober travel, and you get a wealth of resources and opportunities. The next one. We now have also, I am part of what is called a Association of International Recovery Tourism. Did you know such an organization existed? Well, it's relatively new, but what it is an effort by those people that are concerned about reducing the challenge and reducing the risks of people relapsing. We're talking about those that have successfully completed your programs, that we want to talk to the institutions that are providing tourist services. So we say, what can you do for the non-drinking alcoholic? What can you do for the post-drug user? So we even have a hotel in UK. This is the person that's in the head of this organization. The Somerton Lodge on the Isle of Wight in UK is a non-alcoholic hotel. Is a non-drinking, non-drug hotel, that basically provides all the tourist services, all the opportunities for fun and engagement without the liquor or without the drug context. So that's, I think briefly, a little bit about what I'm concerned with. And I'm happy to give you my card. And if you want to discuss this with me anytime in terms of maybe organizing a retreat or organizing a tour, I'm happy to give you that assistance. I think that's enough from me, but sobriety doesn't have to be a sad situation. It can be fun and exciting, you know, especially if you have now been through treatment and have the resources that many of you professionals have provided to the recovering addict and alcoholic. Thank you.
You know, can I add something to what you said? So when I took over the Williamsburg facility, we went through and did an inventory and started recreating the housing program. And I was meeting with my housing manager, her name Christy, recovering addict, and she was talking about all these fun activities. I said, well, all these fun activities, that costs money. What's the recovery benefit? And she said, well, a lot of our patients, they've been addicted for 10, 15, 20 years. They don't understand how to have sober fun. They've spent all of their adult life drinking and drugging, and that being their only way to connect with other people. And they need these sober fun activities to be able to live a healthy, productive life. So, and I wanted to add to that. That was, yeah, I'll have to get one of your cards.
Yeah, okay, you're all welcome to.
Before I turn my own timer on, I'm accustomed to having a podium to hide behind. And I feel a little vulnerable standing up here without one. Although I have an MD behind my name, I'm sharing with you this afternoon, not as a physician, not as a therapist, but as a rehabilitation person, as a rehabilitant. I grew up in Williamsburg and practiced general and advanced laparoscopic surgery in Louisville for 25 years. I was fortunate to make some contributions to my specialty and the science of my profession. I've been affected by the epidemic of opioid and alcohol disorders raging across Kentucky. Years ago, when my stepdaughter exhibited some bizarre behavior, I networked in Louisville and took her to a respected adolescent psychiatrist. He diagnosed her as bipolar and put her on medication. It didn't do a bit of good. And we found out later that she was flushing her lithium down the toilet. After an inpatient evaluation, she was found to be using LSD and vodka. Quite frankly, I think that's better than bipolar. Today she's well, and I love her sincerely. This deeply troubling event initiated a 25-year journey of recovery, seeking support, understanding, and the answers that ultimately would lead to peace of mind. I have presented an international surgical paper in London, England. I've been guest lecturer at Harvard and guest faculty at Yale. But the most single important influence in my life has been this journey to recovery I made through Al-Anon. And then in 1998, I was diagnosed with hepatitis C. My liver biopsy revealed stage 3 of 4 liver damage, and I sought help from a national expert, and he started a form of treatment which was like chemotherapy. I developed severe fatigue and lost my hair, which you can see most of which didn't come back. I've been virus-free since. Severe clinical depression was a result of this early treatment protocol. I was treated as an inpatient in Arizona for a month. Of the 100 patients at this institution, 7 of us were there for bipolar or depression, and the other 93 were there for alcohol and substance abuse. Much of the therapy that I had was alongside these patients. Treatment of addictive disorders starts with professional help, but prevention of relapse variously estimated to be between 40 to 60%, if not higher, needs more study. I was astounded and saddened to learn that my friends there had a relapse rate of almost 70%. On leaving the treatment center, I really felt good. I and others really felt good about ourselves and our future. My former wife had attended Family Week with some resentment, despite having 3 members of her immediate family who were alcoholic. She did not buy into the principles of recovery. Cultivation of recovery is more difficult in a cold and cloudy environment. On returning to Louisville, I referred to the #1 Al-Anon group at Highland Presbyterian Church. Notes taken after group meeting, after step study group, from my sponsors and others were placed in my journal. I kept this for 25 years. And the journal was useless. I couldn't find anything that I needed. So I started transferring the material to a Word document, and after 2 years and alphabetizing it came my recovery companion, which I was asked to bring today. It takes the issues from, it's almost like having a group in your pocket. It's estimated that an addict's behavior affects 5 other people. I think that's low. Before treatment, an addict's dysfunctional behavior affects several sets of people, including their spouse or companion, their children, and their extended family. Expectations of a returning alcoholic are often unrealistic. I believe that more emphasis needs to be placed to family education, involvement of the family in the program and aftercare, and I think this would affect the relapse rate. Next, the alcoholic's behavior is affected in work environment and his co-workers. This is especially true in the presence of a stressful job. More emphasis and preparation for work re-entry while in treatment would help. Finally, the alcoholic's friends are affected, and they often contribute to a toxic environment by stopping by for a beer after work on the way home. This is one case where it's honestly true that birds of a feather often fly together. It is said you can't change your family, but can change your friends. While this is largely true, it's hard to do. On release from inpatient therapy, all the triggers are still there. The environment has a huge impact on the use of alcohol. When you take an alcoholic that's been introduced to the rudiments of recovery and throw them back into the same swamp they came from, no wonder the greatest recurrence rate is within the first 90 days. It's a surgical maxim that the longer it takes my patients to get sick, the longer it takes them to get well. After initial treatments, many addicts still suffer from the delusion that stopping drugs or alcohol will control the problem. Not true. I believe recuperation requires a spiritual foundation. That comes late for some. It took over 2 years for my spiritual light bulb to come on. When you ask most people why they go to Al-Anon, it's to help somebody else. Well, I went to fix my former wife and treated Al-Anon initially as a self-help program. Other factors affect relapse, including severity of the addiction, the consequence of, and the presence of concurrent diseases, psychological and physical. Addictions, and believe this is true, addictions untreated or treatment failures with relapses are invariably fatal. What more reason do you need to study relapse than this? In a 10-year study, it was found that relapsed patients died 9.5 times the rate of matched controls. They die of chronic disease, liver failure, heart failure, stroke, and cancers in the gastrointestinal tract. Yet another reason to concentrate on prevention of relapse. In the Cochrane Medical Database at Oxford, and this is the gold standard of medical information and research, very little is found about relapse prevention. In the Google Scholar Medical Database, 44% of the first 50 citations only were published within the last 20 years. More legitimate research is needed to relapse, including the promise of medications. The 3 factors in addiction are genetic, which may be responsible for 50%, and I think is one of the most understudied factors. Environment and mental health, they all need our attention. In conclusion, let's all support increased involvement of families in the rehab process and aftercare. Let's support broader and more inclusive aftercare programs improving effectiveness. And let us all give more love and compassion for those suffering from this fatal disease. Thank you. I'd like to open it up for questions. And this is just a wonderful, casual, relaxed session. And let's open it up for questions from the panel. All right? I'll start out. What are some of the underestimated difficulties in living a sober life?
Underestimated, well, I can tell you that at Horizon, a lot of the patients that we've treated had a problem with transitioning from that addict stage of mind into stable employment. And then once they got there, the challenges they were faced with, how to maintain their sobriety while they were working in an atmosphere with people that may honestly trigger them, for lack of a better word, because of what they're doing. So I believe that as we continue to grow and educate the public about this issue, that we need to provide more in-depth training and education specifically on maintaining your work and your home life without being triggered back into relapse.
What I saw, and I'm talking as a patient now, what I saw when I got home, nobody knew what I was talking about, boundaries and so forth. And I think something to give the families a talking knowledge, a working knowledge of what you've been through would be helpful. Are there any other comments on that?
I have one question.
Please.
It's, a family aftercare program. Yeah, I'm thinking about our area here. What types of activities would you recommend if someone were to start a family involved aftercare program for the patient or the client? What would that look like?
That's a good question.
That's a good, Zach, do you have a response to that?
Family involved aftercare. Well, one of the biggest things, and you know, when take a step back, when you got someone going through recovery, they're going through a lot of changes, and they don't know what they're finally going to look like, and their family doesn't know. Their families only experience them as one type of person, but they're in the process of becoming a completely different type of person. So building that understanding within the family as to how they are changing and how the family is going to change, because the family's seen them as one type of person. So they built a set of actions and reactions and defense and coping mechanisms related to that old person, and trying to get them acclimated with the new person is challenging. So when I think about activities or things that might help with that, I'm thinking activities that would give them more chances to communicate and more chances to be open. So what does that rule out? Well, that rules out trips to the movies, right? You go to the movies, you go watch Spider-Man, you're in there for 2 hours, it's silent, you come out and, you know, there's no chance for communication. So that might look like activities like hiking. That might look like picnics. That might look like an event where you've got maybe some sort of speaker that kind of brings up a topic for people to think about. If you're in a religious organization, that might look like some sort of a religious event. But the biggest thing is you're trying to help them build that understanding of this person who's evolving. And in order to do that, they have to be communicating.
I like what Zach says. And if I'm not wrong, there's embarrassment from families that they have someone who's addicted. So I would suggest, think about starting off with social events without specific therapy involved, to get people comfortable with each other and then move into some gradual things like that. Other questions?
I think I could testify to the embarrassment.
Pardon?
In regards to family members, when you were talking about embarrassment, my son is an addict. He's been a heroin addict for almost 10 years now. That's one of his big things. He was afraid to be a part of family events because of what other people were saying in regards to us as family. Like, well, how can, his mother condone this? How can his sister literally go and have dinner and things like that? And the way he explained it to me, being in and out of recovery, was just the basics of life, knowing how to do laundry, being able to go into the grocery store and like making a conscious decision, do I want a can of soup or do I want to get some burger? Or, attending a family event for like a barbecue or something, and it just being without the stigma and just being a normal everyday occurrence.
I love that.
That's very true.
That's very good.
Other observations or comments?
Could I add on
Sure.
to what she said? So one of the things that, because in our women's housing program, right, they're there for 6 to 9 months over the course of their IOP. We try to encourage them to reconnect with their families, because a lot of them, when they come into the program, they don't want to tell their family. And that's their right, that's HIPAA, they don't have to. But we try to encourage them to, because, their healing, their recovery can't quite be complete until their family started their recovery process. So we try and get them to get past the shame of it, because in recovery, there's no shame. It's like going to the gym. Have you ever heard someone feel ashamed that they go work out,
Tom, this sounds like this is something right down your alley.
It's something in my area of interest. Certainly, this is where retreats can come in to your process of let's say, dealing with reality of life after treatment. And the treatment facility itself address relationships amongst themselves. They're post-treatment again. They're graduates. So that's my take on this. You can help facilitate, organize, facilitate, and make a retreat happen with your funding. At present, you just simply write it off as ongoing therapy or something. That's it.
As a last, I think we have time for one more question from you guys. Let's talk just a couple about aftercare plans. When I went with all the alcoholics, they wrote out a nice aftercare plan for me when I got back to Louisville for my depression. And it was to see a clinical psychologist once a week. And that just didn't cut it. And fortunately, the drug counselor, who's a friend, referred me to Al-Anon. And that really became the focus of my recovery. And remember, Al-Anon is not going to meetings once a week. You meet with your sponsor to do step study. Okay, and there's other things. Do you have any final comments on aftercare plans
Yes.
or
I
fractured
think-
aftercare plans?
Sure, we do aftercare planning with our patients, and one thing that I didn't hear anybody mention that I'll go ahead and say that we use as an element of that is we do try to involve the family towards the end before they go into their aftercare. We try to involve the family in some of the sessions if it's available, if they're willing. Because not only are you treating that person, but the family has also suffered with that person and has been there through the bad times. They've seen the behaviors, so they've been traumatized to a certain degree as well. So we try to involve them in aftercare planning and also in how they can be supported. Education on how they can support
That's good.
this new person's life that's coming back into their life and things that they can do to help with that. And it really strengthens and empowers the family that way.
All right, as we end, you all are invited to come up and say hi to the parents. If you want to see this disaster notebook, it's up front. And I want to thank you This has just been so pleasant. Thank you all very much, and thank the panel for
Thank you.
really
Thank you.
the inspiration.
Yeah, I was there when it was